I think one of the best tests to do if you only have 2 minutes to evaluate a patient in adult acquired flat foot is to do the single foot heel rise. The single foot heel rise in a healthy patient, the patient will lift their heel at least 4 to 6 inches off the ground, and the hind foot will invert, as you see in this patient. In a patient with adult acquired flat foot, as they attempt the heel rise, the heel will not rise off the ground, and instead you'll see the midfoot collapse. You'll see the rear foot plantar flex on the forefoot across the mid-tarsal joint. It doesn't matter how flat their foot is. If they have healthy ligaments, as this 74-year-old patient who's a marathon runner, his feet look terrible, but you ask him to do a heel rise, he has no problem whatsoever. He has a flat foot, but it's a healthy foot. And it's a healthy foot because his ligaments are intact. And the way to test it is you have him do a heel rise. To do a heel rise, you have to have a stable midfoot. You have to have a stable mid-tarsal joint, and you have to have a spring ligament that is intact. In patients with an unlocked mid-tarsal joint, as they attempt the heel rise, the rear foot plantar flexes on the forefoot. This is a classic case of not just a ruptured PT tendon, but a ruptured spring ligament and an unlocked mid-tarsal joint. This is the first metatarsal rise test demonstrated by Beat Hinterman, wherein at any patient's foot, if you supinate their foot in a weight-bearing position, the first metatarsals should stay on the ground. But Hinterman observed that patients with adult acquired flat foot and ruptured ligaments, if you externally rotate their tibia, the first metatarsal rises off the ground. Very interesting. So we take this patient and we supinate their hind foot, and the first metatarsal rises off the ground. It rises off the ground because the ligaments are ruptured. There's no coupling between the forefoot and the rear foot. It's also demonstrating what we recognize to be a forefoot supinatus deformity. This is not a forefoot varus, it is reducible. If we push down on the first ray, we can reduce it. That is not a forefoot varus. It is an acquired forefoot supinatus that we see in every patient with stage 2 adult acquired flat foot. You do not need to do an MRI to detect a rupture of the posterior tibial tendon. I learned this in podiatry school from John Weed, who taught me how to isolate the posterior tibial tendon and easily detect a loss of 1 grade of strength in the posterior tibial tendon. But it must be done properly. You draw an imaginary circle on the medial half of the head of the first metatarsal. You place your thumb on the bottom half of that circle and you push the foot to end range pronation or eversion. You leave the ankle plantar flexed, and then you ask the patient, push against my thumb. Push your foot against my thumb. And you can easily detect a loss of 1 grade of strength when you compare to the contralateral foot. This will detect attenuation and easily detect rupture of the posterior tibial tendon without requiring specialized MR imaging. This is the improper way to do this test, because the patient is allowed to begin the test in a supinated position where they can now activate the tibialis anterior, which will give a false grade of inversion strength not provided by the posterior tibial tendon. When we cast a patient in adult acquired flat foot, we must remove that forefoot supinatus deformity. And we do this by pushing down on the first ray of the foot. This does not change the position of the subtalar joint, it reduces supinatus. And we will show you this in the casting workshop tomorrow. Finally, a very easy test to do is called supination lag. When a patient hangs their feet off the end of the exam table, you ask them to supinate their feet, or you hold your hands up and you say, bring the soles of your feet together. If they have ruptured their posterior tibial tendon, the foot with the ruptured tendon will lag behind, or it will not cross the midline, as this patient's right foot demonstrates. This is a patient who has ruptured his left foot posterior tibial tendon. He cannot cross the midline when commanded to do so. This patient has ruptured his right foot posterior tibial tendon, the right foot does not cross the midline. Finally, we check for contracture of the gastroc soleus, the silver skull test, which isolates the gastrocnemius from the soleus. This is important to detect in the non-operative intervention by imparting stretching and flexibility, and it sometimes can be important from a surgical standpoint in doing a gastroc soleus resection. So if we take a patient in adult-acquired flat foot, we check for flexibility and reducibility. We look at their lateral malleolus. We do a supination lag, which in her left foot is lagging behind. We do a first metatarsal rise. On the right foot, it's healthy. On the left foot, the first metatarsal rises off the ground. She can easily perform a single foot heel rise on her right foot, but she cannot do so on her left foot. This patient has ligamentous rupture. She will not respond to traditional foot orthotic therapy. The reason is the foot is disconnected from the leg. In order to reconnect the foot to the leg, you must do it with plastic. You must connect the tibia to the foot through a hinged ankle-foot orthosis. And I'm just going to finish with a couple videos. These are typical patients with stage 2 deformity, unilateral in almost every case. And they're all women, and the reason is that this deformity affects women 5 to 1 compared to men, and we don't know why. Plantar fasciitis, plantar heel pain syndrome, affects women to men 2 to 1. And these are just some before and after. You'll notice in each case, the women are wearing athletic shoes. It's not a requirement, but it's the ideal shoe to take a brace like this because it has a deep heel cup, it has a removable footbed, and it's lightweight. Here's a patient in stage 3 adult acquired flat foot on her right foot. This is a rigid, non-reducible deformity. You're not going to correct this with a brace because it's fused, it's rigid. But what you can do is decompress the joint with offloading. And that's what we do with this device. It's called an arch suspender. And it is very effective in adjusting the height of the talonavicular joint with a lifting strap, and it decompresses the forces on the medial column of the foot and the medial ankle. Before and after. This patient I've shown in previous slides. I took this slide 7 years ago. She has very badly pronated, broken down feet, but only the right foot was symptomatic. This patient no longer wears a brace. She wears foot orthoses and she's been pain-free for 5 years. And that's a very typical result if you approach this functionally. This is a stage 4 adult acquired flat foot. It's a stage 4 because the ankle is involved. They've ruptured their deep deltoid ligament. The talus has dropped into severe valgus deformity. And this is a great indication for the very popular gauntlet-type braces in the United States, also known as the Arizona AFO. The gauntlet is a very rigid, restricting brace, but it's used when we have a rigid, severe end-stage deformity, as you see here. So gauntlet braces are used to address a severely arthritic ankle. They require extra depth shoes, very high volume shoes, because the braces take up a lot of room in the shoe. To make these braces available, an innovation was developed in the United States using a simple sock that's impregnated with acrylic. It's dipped in water, and it forms a beautiful three-dimensional model of the foot and leg in just a matter of minutes, making the casting process very easy to do. And we will be demonstrating this in our workshop and at our booth. Our workshop is tomorrow, Friday, October 18th at 12 noon. And we will be in our booth for the next 3 days to show you the casting procedure. And you can order one of our special formal dress-up braces for nighttime wear. Thank you very much.
Any questions for Dr. Richie this morning? Thank you very much. Thank you for your kind attention. We will now break for lunch and have a good rest of the day. Thank you.